Beyond Uric Acid, using microbiome testing to manage gout, presented by Dr. Amber Sedera.
All right, let's get started. So, what are the learning objectives for today? What I want to take you through today is an introduction to our new add-on, the StoolOMX report. Whether you've seen it or not, we're going to go through it. We're going to talk about bile acids, so primary and secondary bile acids, short chain fatty acids, saccharolytic and proteolytic fermentation. And then I'll have a case study example, which we're going to go through, which is focusing on gout and what information can we get from the GI-MAP and the StoolOMX, and how do we use that information to build a treatment plan. I'll also highlight when we might want to consider adding the StoolOMX to the GI-MAP, and I will also leave time for questions, and that will be at the end. Okay, let's get started. So this is the StoolOMX, and it is an add-on only for the GI-MAP. It's a 3-page report with a summary page on the front. We get to see 25 bile acids, both primary and secondary, and they're represented in both percentages and absolute quantifications. We also see 9 short chain fatty acids, again, that's saccharolytic and proteolytic fermentation metabolites, and those are also represented in percentages and quantifications. So I'm just going to take you through what that looks like, and then we're going to dive in deeper. So page 1 here, this is that summary page I was referring to. The top half is going to reflect bile acids, and the bottom half is going to show us those short chain fatty acids. So here we have the total bile acids, our secondary bile acids, and our primary bile acids. And the secondary and primary are represented in a bar graph in their percentages. And then right underneath here in the donut charts, you're going to see the percentages represented in a different way. You'll see the patient results on the left and the reference range on the right. And then in the top corner here, we have the LCA to DCA ratio. This is 2 of our prominent secondary bile acids. And on the bottom half, we have our short chain fatty acids. So we see our total major straight chain fatty acids, and then the individual percentages, again, represented in the bar graph. And then in the donut chart, where again, you see patient results on the left, reference range on the right. And then we have our straight chain to branch chain fatty acid ratio. And again, if all of that feels new to you, I'm going to go through what each of those mean. I just want to orient us to what we're looking at here. The middle page of the StoolOMX add-on is to dive deeper and look at our total primary bile acids and secondary bile acids and get a look at what they look like individually. So primary bile acids on the top, and the total there, our secondary bile acids on the bottom with the total at the top of that section. And then the last page of the StoolOMX add-on is a breakdown of the quantification or the numbers for our saccharolytic and proteolytic metabolites. You've got saccharolytic on the left and proteolytic on the right. And then at the bottom of that page, you've got a visual representation of the physiology for bile acids and short chain fatty acids. So that's our orientation generally to the StoolOMX. Again, we're going to see these repeated through so that they start to get into your mind a little bit, but we need to be able to understand what we're dealing with here. So I want to go over some basics. So what are bile acids? And we're starting here with primary bile acids, which are made in the liver from cholesterol. They are then conjugated or tagged with taurine or glycine to make them more water soluble. Then they're going to be stored and concentrated in the gallbladder, and they're going to be released in response to eating, specifically fats. And they're going to aid in the emulsification and absorption of fat. And you can think of emulsification as like a detergent action. So it's going to help to break down those fat globules into smaller pieces for digestion and absorption. In a normal functioning system, we're going to expect that 95% of those primary bile acids are going to be reabsorbed at the end of the small intestine, which is the distal ileum. And then the last 5% should move to the colon and become unconjugated secondary bile acids. This transformation is a result of a healthy microbiome. Those microbes are responsible for transforming our primary bile acids into secondary bile acids. So now that we know that the role of our primary bile acids is fat breakdown and fat digestion, what are the roles of the secondary bile acids? Because those have far-reaching effects throughout the body. So I'm going to highlight a few really important ones here. They have antimicrobial properties to help modulate the microbiome. They act in immune regulation, specifically on regulating the Treg cells, which is going to have a big influence on the balance between inflammatory and anti-inflammatory immune responses in the gut. It has big impacts on motility, metabolic health, and mucosal health. So again, really far-reaching effects of our secondary bile acids. Now, these next few slides are going to focus on the transformation from primary bile acids into secondary bile acids. There's two main steps, and both steps require enzymes from our normal flora. So step one is called deconjugation, and it is going to be achieved by using bile salt hydrolase from some of our normal flora. And then step two is called dehydroxylation, and that is going to be using 7-alpha dehydroxylase, also from some of our normal flora. So these next two slides are going to show you which of our microbes have these enzymes. And what I want you to get from this is that on the left, you see the microbes that we see on the GI map, and on the right, we see the microbes that we don't see on the GI map. So this is just reinforcing that we get extra information about the microbiome based on the balance of our bile acids. And so those were the bile salt hydrolase, and these are the ones that have 7-alpha dehydroxylase. Okay. So those were our bile acids. Now let's break down our short chain fatty acids. So short chain fatty acids are small fatty acids that are 0 to 6 carbons long, and they're produced by our bacteria, our normal flora, through fermentation of dietary carbohydrates and proteins. So our overall heading here is short chain fatty acids, and we've got two groups underneath this. Our first group is called saccharolytic straight chain fatty acids. And the potentially confusing part about this is that this group has the same abbreviation, SCFA, as that heading, short chain fatty acids. So just keep that in mind when you're looking at the report. At first, it can feel a little bit confusing, but our main heading is short chain fatty acids, and then we have our saccharolytic straight chains, which is our first group. And we expect that our pool of short chain fatty acids are 90 to 95% saccharolytic straight chains. Our other group are our proteolytic branch chain fatty acids, and those are a result of protein fermentation. If I didn't mention, saccharolytic is carbohydrate fermentation, and our proteolytic branch chains, we expect them to make up about 5 to 10% of our short chain fatty acid pool. So looking at that bottom half of the StoolOMX summary page, this is what we see. Again, we see that total major straight chain fatty acid number, and then we see our percentages of our individual straight chains, both represented in the bar graph and down at the bottom here in our donut charts. Now, this is a reference slide from the interpretive guide, and it shows you which microbes produce which straight chain fatty acids. And so this is, again, just another reinforcement of the additional information that we're getting about the microbiome based on what we're looking at with our short chain fatty acids. Okay, so now that we've done our background, I'm going to give you this overall view of what we're going to look at for our case. So our case today is a 39-year-old male with gout and diarrhea. So his main concern was gout. The onset was as a teenager, but he wasn't diagnosed until his late 20s. Now, it's important to note here that it can take a really long time for somebody to get diagnosed with gout, especially when they're in their younger years, because there's this misconception that gout is a disease of the older indulgent man, which hopefully I'm going to break that myth for you today. That's not true, but that's, you know, we get in the textbooks and things like that, the king sitting on his throne, drinking his red wine and eating his red meat, which is the picture that I always have in my head. But it can impact people at any stage in life. And so it did affect him as a teenager, but he didn't realize that until his diagnosis in his late 20s. And he could look back and go, oh, that's what that was. Because he played a lot of sports, he thought he was just getting, you know, minor injuries or things like that. But once he knew what it was, he could tell that, oh, you know, this has been going on for a while. Now, for this patient, multiple joints are affected. So multiple joints in his feet, his ankles, even his larger joints. They're more rare, but they do happen. So the knee and the wrist, and then he feels it a lot in his finger joints as well. He does have a strong family history of rheumatoid arthritis. This can also be a key as to, you know, putting gout on our DDX list is this history of arthritis in the family. And this patient uses, so colchicine is a pharmaceutical for managing acute gout flares. And this is what he's using when he has gout flares, which he has very, very frequently, typically somewhere around once a month. And when we look at the literature, the definition of frequent gout flares is more than 2 in a year. So this is a ton of gout flares. And about half the time he'll take Advil for the pain, but he doesn't really find that makes a really big difference. It's the colchicine helping the body to decrease the uric acid that's really making the difference for him. But that prescription is really hard on his digestion. It turns his diarrhea into a very urgent diarrhea, but still worth it for him to take to decrease the duration of that flare. The triggers for him are getting sick, dehydration, specifically a hazy IPA or unfiltered beer, and lots of oysters. And then stress is really high, about an 8 out of 10. And we'll see how this impacts the microbiome. And this is really important for us to note because the nervous system plays such an important role and works synergistically with the gut. Now, the secondary concern here was the diarrhea, and I suspected bile acid diarrhea, and that's part of why I ran the StoolOMX here. He's had this going on for many years. He doesn't really know the exact timing. On a normal day, he'll have 1 to 2 bowel movements, but it can be up to 3 to 5 times, especially in the morning. Without the colchicine, he would describe these as non-urgent. The form is all over the map. There's no undigested food or blood, but it does feel incomplete about a quarter of the time. He also has this quality to the stool that leaves this like streaking or stickiness on the toilet bowl. It's hard to flush down. So that was one of the symptoms that led me to think about bile acid diarrhea or bile acid malabsorption. He occasionally reports mucus, and his Bristol stool chart, he's mostly a 5-6, so the softer stool. He has had type 4, so he does know what a normal bowel movement is like, but it's really occasional for him. So now that I've set up a case for you, we're gonna talk about the basics of the physiology of gout so we can understand how this is impacting the gut and vice versa. So gout is considered a metabolic disorder involving hyperuricemia, which simply means elevated serum uric acid levels. So at the top of this flowchart, you can see purines, and we're thinking about adenine and guanine, and these are breakdown components of RNA and DNA. And this is gonna be from diet and breakdown of our own cells. And so I wanna point out that most studies found that controlling diet is not enough to completely manage gout. It helps, but it's not that complete cause or answer. So that's another piece that I want to kind of break that myth that it's this disease of overindulgence. And yes, diet we know makes such a big impact on the gut and all systems of the body, but I just want to point out that it's not the only thing at play here. So some people with gout can have a perfect diet and you wonder, why is this happening? And then the second point there is it's really important that we understand that our dysbiotic gut bacteria can upregulate that purine metabolism. And as you can see that next, the breakdown of purines leads to uric acid. And uric acid, the conversion from purines to uric acid is mostly happening in the liver and a small amount in the small intestine. So then with gout, we're going to have increased production or decreased excretion or both. So dysbiosis, again, can reduce the population of microbes that help to degrade or break down uric acid into a more soluble form. And we're going to look at that later. It's something that we as humans can't do, but that some of our microbes can do. So when we have that increased production or decreased excretion, that's going to lead to this hyperuricemia or elevation of uric acid in the blood. That in turn is going to lead to the formation of monosodium urate crystals, which triggers that inflammation and it deposits in joints. So that's part of the acute gout flare piece. Those crystals then activate the specific inflammasome, NLRP3, which is from macrophages, and that's going to also trigger the release of more inflammatory mediators, specifically interleukin-1 beta, TNF alpha, and interleukin 6. So as we saw in the last diagram, those monosodium urate crystals stimulate that abnormal secretion of that inflammatory mediator, interleukin-1 beta, and that's what triggers our acute gout flare. Now, how do we get rid of uric acid throughout the body? Where can we have issues with this clearance? So most of it, 2/3 of that uric acid is going to be cleared through the kidneys, but 1/3 of it is actually excreted through the intestinal tract. And so dysfunction here increases the risk of hyperuricemia. We have a huge opportunity here to modify the intestinal breakdown and excretion of uric acid. And just a reminder that, again, gout is a systemic inflammatory disease. So even when they're not in an acute flare, we need to be monitoring their uric acid levels in their blood because there can still be inflammation happening and triggered by uric acid that's too high. So I kind of think of it like shards of glass moving through the circulation causing damage. And this is what leads to higher risk for really important diseases like chronic kidney disease and cardiovascular disease. So the figure at the bottom is showing the very basics of uric acid excretion through the intestinal tract. So number one at the bottom here is showing that our intestinal flora have enzymes that break down uric acid directly, which I alluded to in the last slide, and we'll look at again coming up. In this second spot, some of the metabolites that are produced by our normal flora can upregulate the expression of our uric acid transporters, which again is going to be a pathway of excretion. And then this last one here is some of the metabolites are going to promote excretion or clearance of uric acid indirectly. And they're going to do that by providing energy for the intestinal epithelial cells. So here I'm thinking about short chain fatty acids, because if the epithelial cells don't have enough energy or short chain fatty acids, they're not going to be able to assist in effectively helping to clear that uric acid. So what does this potentially look like as a clinical presentation? So when someone has an acute gout flare, it's usually sudden onset, often at night, and they're going to have this redness, swelling, heat, and very intense joint pain. So if you've learned about this previously, you might, there's this reference where they talk about the brushing of the bed sheet over top of the joint being super painful and intolerable, which is quite true in these flares. So it's, as I was saying, it's typically described in that first metatarsal joint, so in the big toe, but it absolutely can impact any joint and larger joints, which lead to that systemic inflammation. So here I just want you to think about when we have joint pain, even if it's not in the toe, just keeping that gout picture in the back of your mind, and testing serum uric acid can be a really helpful way of looking at this. Neutrophils are going to amplify this systemic inflammation, and the acute flare is typically self-limiting over days to a week. So you might ask yourself, if it's self-limiting over days to a week, then why are they taking something like colchicine in an acute flare? And it's because when they have an acute flare, it is so debilitating and changes their ability to do daily tasks. So those couple of days of reducing the flare can make all the difference for people. So just solidifying some of these connections that we have with gout and the microbiome, I've been talking about the bacteria, some of our bacteria being able to break down uric acid further than we can as humans. And we can see that here. So this is the final metabolic pathway in humans, is that uric acid, and then we have to clear that. But some of our normal flora have this enzyme, which is referred to either as uric oxidase or uricase, which you can see transforms uric acid into allantoin, which is a much more soluble, easier excreted molecule. So the changes in the composition and abundance of the microbiota can raise serum uric acid levels by reducing its breakdown and increasing its production. So again, these are all potentially modifiable factors that we can work on. And what we see with hyperuricemia, or those elevated uric acid levels, is that can lead to compromised intestinal barriers. And specifically, we see a drop in tight junction protein, so specifically occludin and claudin-1. And when we have that increase in permeability, microbial components can enter the bloodstream much easier. So things like LPS, which is quite inflammatory, which is going to increase that systemic inflammation and worsen the disease progression. And so you can see there, we get increase in systemic TNF-alpha and LPS. And as I've been talking about, short chain fatty acids can have a protective role, especially that butyrate, really important for feeding those intestinal epithelial cells. So let's look at this in graphic form. So this is looking at how bile acids and short chain fatty acids help to decrease inflammation in uric acid. So on the left here, we have bile acids, and you can see that they directly decrease that inflammatory mediator, interleukin-1 beta. And same thing with our short chain fatty acids. You can see that arrow going to that same decrease in interleukin-1 beta. Our short chain fatty acids can also decrease one of the enzymes that is used in uric acid production. So that's going to be the XOD enzyme, and all of that is going to result in decreased uric acid. So again, modifiable factors, we're going to look at these short chain fatty acids and bile acids. And just a few characteristics of the microbiome of gout patients that we see in the literature. So overall, we tend to see an increase in strep species and candida species. Overall, we see a decrease in Faecalibacterium prausnitzii, Clostridium species, Ruminococcus species, Saccharomyces boulardii, and in general, our short chain fatty acid producers. And I should add S ratiate to that. We will see it coming up in our case. So just a quick refresher on our case before we look at the test results and what we're going to see here. So again, long-standing gout, multiple joints affected, family history of arthritis, using colchicine to manage. We've got some triggers there, high stress, and then we've got this secondary diarrhea that's happening. So let's look at the GI-MAP and the StoolOMX results. So page 1 pathogens, we're not seeing anything here. We have a low level H. pylori, which is not top of my mind in this case. This could absolutely be commensal for him. He doesn't have any big upper GI symptoms, so I'm not thinking about that as a big player at this point. When we look at the commensal section, which is the bottom of page 2 of the GI-MAP, we see a few things. So I always start by looking at this bacterial phyla section at the bottom. because these two groups together are about a 90% representation of the microbiome. And we can see that the Bacteroides phyla is headed towards overgrowth. And we'll see later in the StoolOMX that this is likely partly responsible for the higher propionate levels. The Firmicutes phyla is trending towards deficiency. Some of these microbes in this group, some of these bacteria are butyrate producers. And then some of our characteristics of the microbiome of gout, we are seeing that low Serratiae or headed low and low Faecalibacterium. Faecalibacterium, another one of our big butyrate producers. We're also seeing a less than detectable limit Akkermansia, and Akkermansia may help to reduce uric acid levels by inhibiting that enzyme I highlighted earlier, that XOD enzyme that facilitates the conversion of purines into uric acid, and it can help to increase the excretion of uric acid as well. So on page 3 here, the opportunistic section, as I mentioned earlier, strep is a characteristic for the gout microbiome, but it's also, along with staph, characteristic of weak digestion. So when we have low stomach acid or weak digestion, staph and strep tend to be the first to overgrow. So they're really common for us to see. And this is likely due to those stress levels I was talking about. When stress is really high and someone's more in a sympathetic versus parasympathetic mode, digestion is going to take a back seat because it's not a survival mechanism. We're also seeing some low levels starting to pop up of Pseudomonas and Citrobacter, which are also inflammatory. So thinking about histamine production and LPS production. We talked about LPS production getting through a compromised barrier, leading to systemic inflammation. And then we see Candida. And again, that was one of our characteristics of the gout microbiome. And we see, that is much more prevalent in our gout versus our non-gout groups in multiple studies. And I'm going to highlight some links with Candida as we move through the report. No parasites, no worms. In the intestinal health markers section, really the main thing I wanted to point out here is this elevated secretory IgA. So probably partly in response to that Candida, but can also be reflective of barrier dysfunction leading to food sensitivities, because secretory IgA is really important in food tolerance. Let's look at what we see on the StoolOMX for this patient. So we're starting with the top half of that summary page, the bile acids section. This first number is total bile acids, which are starting to trend towards elevated. And this is going to be, again, a combination of our primaries and secondaries. So here I'm thinking synthesis or production of bile acids is not deficient. So I'm thinking about potentially overproduction, issues with conversion, or potentially issues with reabsorption in that distal ileum. We're seeing high primary bile acids. So again, I'm thinking about potential impaired reabsorption in the distal ileum and, again, impaired conversion. And our secondary bile acids are low. Again, that lack of conversion from primaries to secondaries, this can, really reflect low microbial diversity. So even though the commensals didn't look super terrible, this is the benefit to being able to see bile acids and short chain fatty acids, is that we can see potentially some deficiencies that we might not see as clearly when we're looking at the commensals. Candida can also impact this. If it's in the large intestine, it's going to reduce our bile acid converting bacteria. It's also going to compete with commensals for nutrients, space. It can alter the pH and mucin production, making it less favorable to our commensals. I want to point out this donut chart that looks a little bit unique, and that's because the other category, or that red category, includes primary bile acids. And those are, we'll see in a minute, those are all elevated in this case. And so the primary bile acids are dominating over everything else. So that's why that donut chart, the patient results, looks pretty red here. Then in the corner here, we see the LCA to DCA ratio. Again, these are two of our prominent secondary bile acids. And what we'll see when we look at the absolute numbers is that DCA looks fine, but LCA is a little bit on the low side. So again, this can indicate some selective impairment in the microbes that are doing the conversion to LCA. So what connections do we have with Candida and bile acids? So our primary bile acids, TCA specifically, can promote Candida colonization by suppressing host immune responses and disrupting beneficial gut bacteria. And again, I'll show you in a moment, but they're all elevated for this patient. On the other side, our secondary bile acids, which were generally low, can inhibit Candida growth and morphogenesis, which will contribute to colonization resistance. So LCA and DCA specifically possess direct antifungal activity against Candida. And as I was saying, we'll see DCA was fine, LCA a little bit on the low side. So here is this middle page where we're just going to look at the top first, and this is the total primary bile acids, and you can see the total primary bile acids are high along with each of the individual primary bile acids here. And if you're to look at the exponent numbers on these and you look at the reference range, each of these primary bile acids is significantly elevated. They're 1 to 2 orders of magnitude higher than the reference range. And so the link to the diarrhea piece, or the bile acid diarrhea piece here, is that when we have too many primary bile acids entering the colon, they're going to be very irritating to the colon and induce diarrhea. So this is that, again, that connection to the bile acid diarrhea part. And then on the second half of the middle page, the second page of the StoolOMX, we are going to see the secondary bile acids. And so you see the total number there. And I want to point out that the general trend here is low, but we are seeing some of the secondaries high. And I just want to point out a couple specific ones here. So we see UDCA, GUDCA, and TUDCA. And these are all hepatoprotective bile acids. So we might be seeing some shunting towards like a repair pathway, possibly in response to, you know, mucosal stress or some of this microbiome dysfunction. So that was the bile acid section, and now we're going to look at the short chain fatty acids. So this is back to that summary page on the bottom half. And what we see here is that the total straight chains look good. Acetate looks good. And I've been talking about this low butyrate. And when we looked at the commensals, we saw low Faecalibacterium, starting to trend low Roseburia, and starting to trend low Firmicutes phyla. So again, this is going to mean that there's low availability of food or energy for those colonocytes, which can lead to impaired barrier function, contribute to inflammation. And remember, feeding those has a big role in helping with uric acid excretion. I mentioned this propionate briefly, partly likely due to that starting to trend high Bacteroides phyla. But the other reason this might be looking high is due to, again, the diarrhea, the fast transit time. When things are moving through the colon really quickly, there's less time available for absorption of our short chain fatty acids. And then we see this low valerate, and this can be reduced fermentation of longer chain fibers or protein, or lack of microbes that should be producing them. The ratio here of our straight chains to our branch chains are low, or our straight chains are low, but you'll see in a minute that our branch chains are very low, which is what's skewing this ratio. So it could reflect incomplete fermentation, especially with our low branch chain fatty acid values. We're going to see those in a minute. So what do our short chain fatty acids do for us? So they regulate the function of the intestinal epithelial cells. They can decrease inflammation, and they really help to maintain this homeostasis of the intestinal mucosa. So again, as I just mentioned, propionate and butyrate are providing ATP or energy to the intestinal epithelial cells to help promote uric acid excretion. Impaired butyrate production is very characteristic in gout, what we see in the literature, and we can see here that it was significantly impaired. And we have, there's a mouse study that showed that production of short chain fatty acids is positively correlated with the effectiveness of treating hyperuricemia. So this is with medication. The better balance of short chain fatty acids that someone had, the better response they had to treatment. And then our good friend fiber shows that it can help to, if we have a high fiber diet, that can decrease the inflammatory response that is induced by those monosodium urate crystals. And this is done through fiber being fermented into our short chain fatty acids. Take home message here, good levels of our short chain fatty acids are protective in gout. And so what are the connections between candida and short chain fatty acids? So short chain fatty acids create a drop in pH that's going to be less favorable for candida growth. The acidic pH plays a really important role in inhibition of that candida. And in vitro, and we know in vitro and in vivo are different, but in vitro they have shown that the short chain fatty acids do directly inhibit that candida growth. And lots of studies are highlighting the antifungal potential here. There are some studies that I thought were really interesting that have shown that butyrate and acetate, so good levels of those, can actually potentiate or help if we're using the azole class of antifungal drugs to treat candida. And just in general, candida is a direct contributor to loss of barrier integrity. So here we have candida impacting the barrier and uric acid impacting the barrier. And candida is linked to a variety of inflammatory disorders. So on the last page of the StoolOMX, this is where we're seeing the absolute numbers of our straight chains on the left, branch chains on the right. You can see that they're all low, and this is going to be reflective of that low microbial activity overall. So let me just summarize our most relevant findings before I go into treatment plan and what I was thinking about building this treatment plan. So we had a low level H. pylori, but as I mentioned, in this case, I'm thinking it's on the commensal side, so not on my top priority list to treat. In the normal flora, we had high normal Bacteroides phyla, low normal Firmicutes phyla, low Escherichiae, low Akkermansia, and low Faecalibacterium. For dysbiosis, we had that staph and strep, likely secondary to weak digestion, low stomach acid. We had a little bit of Pseudomonas species and Citrobacter and our candida, that high secretory IgA, again in response likely to the dysbiosis, the candida, potentially barrier dysfunction, and maybe some food reactions as a result. In our StoolOMX portion, we had high total bile acids, overall low secondaries, and high primaries. And then again, our overall picture of our short chain fatty acids was low. We did have that high propionate, which could be from the high Bacteroides phyla and or the fast transit. So let's take a look at the treatment plan. So when I put this treatment plan together, what you'll see is the bolded interventions are choices that I made or were reinforced by seeing the StoolOMX results. So I wanted to look at treating that candida, and absolutely candida can be treated with herbs or pharmaceuticals. I went pharmaceutical here partly for compliance for this patient. We had an in-depth discussion, and this is what he wanted to do. So 1 to 2 months of nystatin, and that is dependent on how he responds. Saccharomyces boulardii, we have tons of literature showing how beneficial it can be without competing candida. And then the support for the normal flora diversity, this was much more robust than I may have initially done with being able to see the StoolOMX. So here I wanted to have butyrate in there because we could see the butyrate producers, but also that number for butyrate was really low. And then for feeding our normal flora, soluble fiber and polyphenol, so that's the resveratrol here. a 50 billion probiotic to help support the environment for the normal flora, and a gut healing powder, because we've talked about, many ways with the candida and the elevated uric acid that's going to damage the barrier function. I also wanted to support the liver bile acid axis here. And so I picked a combo product that contained artichoke, which helps to modulate that bile acid pool. So we want to make it potentially a little bit less irritating to the colon to decrease that diarrhea side of things. And the combo product also had milk thistle in it to support that overall liver function. From a diet standpoint, we talked about that stress and low stomach acid piece. So I did an HCl challenge, and then I recommended very limited or no alcohol, which I think was hard for this patient, but it's very important from many aspects. And then I recommended increasing the intake and diversity of the fruits and veg. And that is going to be the long-term plan for the soluble fiber and polyphenols. Short-term, I'm working on supporting it from a supplement standpoint, but I'm always working on it in the background. And so this is kind of step one in my treatment plan. And I'm going to go over in the next slide a few things that I might consider if this isn't enough to, slow down the diarrhea, get the form of the stools, things like that, and other things that we can think of depending on, again, what comes up on the StoolOMX or what symptoms your patient's having. So a lot of these natural bile acid binders that I'm going to talk about, the research is actually on using them in decreasing cholesterol. And as we talked about at the very beginning, bile acids are made in the liver from cholesterol. And so the mechanism of action of these binders is to bind bile acids. So whether we're doing this for cholesterol or a bile acid malabsorption scenario, they're going to be doing the same thing. So this is what I want to note here, is that supplements are like medications, not a one size fits all. We may have to try a couple of things before we find the one that works for them. So the first one that I'm going to highlight here is psyllium husk. So the husk is actually 70 to 80% soluble fiber, and it's going to bind bile acids to prevent their reabsorption. So we did see, again, that our primary bile acids were high, and a lot of the studies will suggest that it can act similarly to a pharmaceutical bile acid sequestrant. And this would be taken with food for if we're doing it for cholesterol specifically. Again, I think you could go both ways to see the best slowing of that motility and diarrhea. Another bile acid binder is activated charcoal. And then we have lecithin. So lecithin binds bile acids indirectly. I would say the support in the literature is limited, but I do see this used clinically very successfully in some cases. So again, trialing and seeing what works. And from a diet perspective, a low-fat diet in the short term can be helpful in managing symptoms, because if we go back to the flow of bile acids and what they do and why we release them, is our primary bile acids are released in response to eating fat. And so that can, upregulate our production potentially. So in the short term, some people with excess primary bile acids might actually feel better with a low-fat diet. Our prescription options are bile acid sequestrants like cholestyramine. I would say that there's an issue with compliance here because the taste is not great. It's also, I find, a very fine line between them having diarrhea and flopping over to constipation. So I do find that compliance piece can be really hard with the prescription bile acid sequestrants. There are things called FXR agonists. We didn't go through it in this webinar, but that is one of the receptors that regulates the feedback loop for bile acid production in the liver. Not frequently used, mostly because of availability and cost. And then there is potential for GLP-1 agonists. Now, we do need a lot more literature on this, but there was a small short-term study. It was a 6-week-long study with a small number of participants, and it was specifically using liraglutide. And they saw that in the patients that both needed the GLP-1 agonist for, blood sugar regulation, weight regulation, but also had signs and symptoms of bile acid malabsorption or bile acid diarrhea, all of those people got better. Their diarrhea resolved. And so we don't know if this applies to the other GLP-1 agonists. Again, we need more literature, but it is an interesting thing to keep our eyes and our ears out for upcoming. And then I want to think about the basics for quality bile production, which can help in both our diarrhea and our constipation cases. So we need phosphatidylcholine. This is a major component of bile. We need that taurine and glycine. I talked about that at the very beginning, which conjugates our primary bile acids to make them more water soluble. And then we have our choleretic and cholagogue herbs. So these are going to help increase bile production and bile flow. But big caution here in people with gallstones. So that's going to be our cholagogue herbs, and we want to be really aware of that, because if we're creating movement through the gallbladder and they have stones, that can lodge a stone and cause an emergency. We don't want to do that. And then we have 2 of our secondary bile acids that can be supplemented. So we have TUDCA and UDCA, and these can potentially alter the bile acid pool to make it more favorable and less irritating. So can potentially be useful in, again, both sides, the diarrhea side and the constipation side of things. But we would use that page 7, that middle page of the StoolOMX, to guide our decision with using these. If you remember, these were all high for this patient, so I did not choose to use either of those. And then who do we want to think about using the StoolOMX add-on outside of, the specific case we just saw? So motility issues, we have the best evidence for motility issues in the literature with bile acids and short chain fatty acids. Our IBS-D patients, up to 1/3 of those with IBS-D have bile acid diarrhea or bile acid malabsorption as their root cause. And this is a huge number. And so the StoolOMX can really help you to see, is that a piece to this IBS-D picture? So it can make a big, big difference. Obviously, we can use it for suspected bile acid malabsorption if we're thinking about that, steatorrhea or fat in the stool, IBD, constipation or slow motility, issues with gut lining or mucosal health, immune imbalances and inflammation, so things like food intolerances or sensitivities, skin conditions like eczema, metabolic disturbances, aging and longevity. And so a few considerations I want to wrap up with here is that it's very important that we combine the stool consistency and motility with our interpretation. So you can see I put the Bristol stool chart here on the right. And if this is not something that you're using in practice, I highly, highly recommend it, because again, we need to know that stool form and motility or transit time to really interpret the StoolOMX results to the best of our ability. Having those StoolOMX results allows us to further individualize those treatment plans and maybe make some adjustments that we may not have thought about in the beginning. And again, to reiterate those insights into those motility issues. So again, that IBS-D that is potentially caused by bile acid malabsorption, or our slow motility constipation side of things. And again, really can be helpful in these inflammation or chronic gut lining dysfunction cases. So hopefully you can see how multi-layered this is and how much information we can get from this. And I want to thank you guys for spending time with me today. And now I'm going to ask Andrea to pop back on and let me know if we have any questions, and I will answer any questions that have popped up.
Thank you, Dr. Sarita. We do have a bunch of questions, actually. The first one is, how does SIBO affect gout flares?
So if we're thinking about SIBO, I like to think about this as a general dysbiosis picture, and we can really get a lot of the information about dysbiosis of our bacteria on those page 3 microbes. So as we saw in the case, when we have inflammatory microbes, that is going to do a couple of things. It's going to contribute to that systemic inflammation picture. It's also going to have an increased impact on that barrier dysfunction, and thus the excretion or removal of uric acid through the GI tract. It can also impact our normal flora, and as we know, again, our short chain fatty acids, the transformation of our bile acids, all of those can affect the excretion of uric acid. So I would say, you know, the general take home there is that potentially the more dysbiosis and gut disruption that we have, the decreased ability to clear uric acid efficiently.
Thank you. Okay, this one's interesting. Will movement make gout more painful or worse?
It's a fine line. I would say mostly worse. So when somebody's in an acute gout flare, especially if it's in their foot or a larger joint, they are not going to want to move. I do tend to see a bit of a trend that it's usually kind of worse at night. As I was saying, we usually get that sudden onset at night and first thing in the morning. And then the intensity tends to decrease a bit throughout the day. But generally speaking, it's really going to be dependent on where the flare is and their level of pain. But generally speaking, they're going to feel worse with movement in an acute flare.
Okay, thank you so much. Would a spore-based probiotic be preferred?
I would say here, you know, if we're looking at specifics, like we have specific literature on specific species, you know, out competing certain things. So if you're thinking about like for example, if we're thinking about Bacillus subtilis specifically, we do have literature showing that that can outcompete staph. So if you're thinking about that, then absolutely. But I would say, again, the basis of support for our normal flora and our microbiome is going to be that food, and the soluble fiber and polyphenols is going to be our most important piece there with helping our microbiome thrive. And as a second side note, dealing with if the nervous system is overstimulated as well.
Thank you. That takes us to our next question, which is what foods should be used to address gout?
Yeah, so I mean, I didn't go into detail. I mean, if the patient coming to you has a not great diet, like a standard American diet, the things that we think about most commonly with gout, and again, we're thinking about breakdown of those RNA and DNA components, but what we see as, you know, our classic food triggers in the literature, which are not going to be true for all people, but red meat and alcohol are big ones. So again, we want to shift the diet into, you know, an anti-inflammatory style diet where we're looking at, again, variety and abundance of fruit and veg. But again, one of the take-home messages I want you guys to get today is that some of these gout patients, and a lot of them, have really great diets, or they have, you know, they know their triggers of, you know, this specific thing or this specific thing. So for this patient, again, it was specific types of alcohol, the certain beers for him, and really just oysters, like the red meat in general, things like that weren't big factors for him. And we do see in the literature, again, they're not that big of factors unless their diet is absolutely terrible, which I know we do see that as well.
Would you add the StoolOMX add-on to all patients who are suffering from gout and diarrhea?
That's a great question. And I would say you can add the StoolOMX on, obviously, to anyone, and you can get lots of good information depending on what their goals are. I would add it on to a gout patient, again, because we can see how the interaction and the, you know, production of short chain fatty acids impact barrier function on all of those pieces. So we can just get a little bit more detailed and a little bit more minute, especially in those people who you've done a lot of work on and you're like, what is, you know, we need to control this a little bit better. That can absolutely give you more information. And the other piece to this that I feel like I may have forgot to highlight is that this patient was not on a long-term uric acid managing pharmaceutical, but that is really important in a lot of people because, again, remember those risk factors of chronic kidney disease and cardiovascular disease, that even when they're not having a flare, most of the time these patients have an elevated uric acid level because their excretion is impaired. So also important to look at things like kidney function as well.
Can GLP-1 agonists be helpful?
So as I mentioned, I would say we're really at the beginning of understanding that. The study that was conducted was by some, I think, really smart researchers that saw the potential for that bile acid diarrhea piece, and then saw that those patients all had resolutions. So there's multiple ways that can be working on a mechanistic standpoint with those GLP-1s. And yeah, I think they have potential. I don't know that we know enough yet about the exact mechanisms and length of time and all of that, but I do think it's a really interesting thing that we hopefully will see more research on so that we can make better decisions.
That's exciting, emerging research.
Yes.
That's all the questions we have for today. We'd like to thank everyone for attending today's webinar, and thank you again, Dr. Sarita. Have a great day, everyone.